The recording will begin now. Jeffrey, you may begin.
Okay, good afternoon, everyone, and welcome. Thank you for joining the UCHAPS Drug User Health Meeting. My name is Jeffrey Campbell. I am the HIV Program Manager for the Houston Health Department, and as such, I'm a part of the UCHAPS membership body and recently took on the role of the government co-chair of our steering committee. I'm very excited about today's webinar, and I look forward to the discussion that we're going to be able to have after our presenter. I want to take time now to introduce our Executive Director at UCHAPS, Mr. Kevin Jones, and I believe Kevin is going to take it now. Hello.
Hello, everyone.
Great.
Thank you, Jeffrey.
Sure.
You know, as always, it takes about 5 minutes to take ourselves off mute, so I appreciate the patience. I'll unmute myself quicker in the upcoming minutes. But on behalf of UCHAPS, I definitely want to thank everybody for joining this call and being a part of today's meeting. Ivory, our program director, and the team have put together an exciting conversation to have us consider drug user health. We're going to, begin with a conversation from one of our facilitators, Magali, and I think many of you have probably met Magali Lerman before. She will moderate the drug user health panel. She is a partner and co-founder at Reframe Health and Justice. Magali combines her personal and community organizing experience with formal education to provide high-quality, customized support to health and justice systems. Previously, Magali provided direct and indirect services to people in the sex trade as Director of Outreach and Organizing at Praxis, and people who use drugs as Development Director at the Harm Reduction Action Center in Denver, Colorado. She supported governmental drug user health infrastructure development as the Drug User Health Fellow with NASDAD, and is consultant on several criminal justice reform initiatives since 2016. Magali received her BA in Self-Determination and Social Change from the Metropolitan University of Denver. So with that, I want to, thank Magali as well as the other presenters that will come up to speak to us virtually. Magali, thank you for being here today.
Wait, can everyone hear me? Seems, hopefully, yes. So I'm really excited to be joining everyone today and excited that the focus of today's meeting is on drug user health, because especially from an HIV prevention and care perspective, drug user health really recognizes that this is one of the core concerns of in the lives of people who inject and people who use drugs, but that there's many other concerns that we have to address, right? Like treatment needs, mental health needs, housing needs. There's all sorts of family and social connection needs that are necessary, and so this means that we have to work with other programs and across silos to really be able to comprehensively address the needs of people who inject drugs. And so today I'm really excited to hear from some of our panelists about how their programs are doing that. So without further ado, I'm going to introduce folks here. So Alex Sheriff serves as the Viral Hepatitis Prevention Coordinator. She works at the Philadelphia Department of Public Health. Alex is the founder of Hepatitis C Allies of Philadelphia, or HepCap, and an active member of the Hep B United Coalition. She has been honored with the Mayor's Award for Distinguished Service and Harm Reduction Hero Award from Prevention Point Philadelphia. We also have presenting today Gail Goldstein, who is the Senior Director of Planning and Programs for the Bureau of Alcohol and Drug Use Prevention, Care, and Treatment at the New York City Department of Health and Mental Hygiene. In this role, she oversees 5 units, including the Recovery Unit, which supports best practice implementation in substance use treatment, the Harm Reduction Unit, which supports the 14 syringe exchange programs in New York City, and the Overdose Prevention Unit, which is tasked with preventing opioid overdose in the city through the distribution of naloxone. Ms. Goldstein has a master's in public health from Columbia University and previously worked on cardiovascular disease, obesity, and tobacco at the Department of Health and Mental Hygiene. So today we'll begin with Alex. I'm really excited to hear more about your program, Alex, and your line is open.
So I'm Alex, and I've moved from the viral hepatitis prevention coordinator role to be the HIV Hep C project coordinator. But before I came to the health department, I actually got my start in public health about 15 years ago, working at an AIDS service organization. So that was kind of how I became interested in public health. I think that through HIV, what really interested me is that HIV was kind of this convergence of all these social issues playing out in a public health and medical way. I did a bunch of stuff after that, and then I've been working on hepatitis at the health department for about 7 years now. I was really surprised when I came into hepatitis that it was so underfunded, it was so under-resourced, that hepatitis was killing more people than HIV in the United States now, and that we were starting to see 7 years ago this wave of new infections happening among people who use drugs, and that didn't really start to get a lot of attention or traction until the Scott County outbreak happened, and there were all these HIV cases happening in Scott County that really kind of got national attention, and hepatitis was kind of this other thing that also happened in Scott County. So I'm really lucky right now for the last about 2 years to have gotten to start working in our HIV program as part of the SPINS project to eliminate Hep C among people with HIV. So we're really thinking in Philadelphia how we can leverage our HIV infrastructure, this tremendous infrastructure that was built nationally, really because of activism and community outcry saying we can't let all these people keep dying of HIV, we need to take care of them. I get to now figure out how we can improve health outcomes for people with HIV, which definitely includes people who use drugs. How can we use this HIV system to improve health outcomes in a broader way? So that's a little bit of background on me. Oh, okay, cool, my slides are up. I have to admit, I sent them at the last minute, so I'm glad you guys could upload them. Can I move it? Can you advance the slide, please? Thank you. So this is Paul, and this is from a meeting of our Hep C Allies of Philadelphia Coalition. Paul was very generous in sharing his personal story of living with both HIV and hepatitis, and he helped us in Pennsylvania advocate for expanded access to Hep C treatment. And because he shared his story, Pennsylvania was one of the first states that had a sobriety requirement removed that said that people who use drugs had to have 6 months clean before they could get Hep C treatment. So in part because of people like Paul who were willing to share their story, we had that restriction overturned. And so Paul did get access to Hep C treatment. He was cured. And unfortunately, despite having HIV and hepatitis and staying healthy and seeing a doctor and kind of using his experience to help others, we lost him last year to a drug overdose. And I think that what his story says is that despite all of the incredible advances that have been made in HIV and in hepatitis to keep people healthy, that addiction plays a huge risk in the people that we serve. And so I think that as a health department employee, while my narrow scope at the health department is hepatitis, his passing reminded me and continues to remind me that despite the fact that sometimes we have to focus on these narrow slices of people's health, we really do need to look beyond our silos in health departments and community organizations and think of more comprehensive strategies that are going to protect people from the harms of drug use, which include HIV, which include hepatitis, and which also unfortunately include death. And so if you go to the next slide, I think that what we see when we look at our local data in Philadelphia, and the print is very small, but what we can see is that because we've had syringe access available since the early 90s, despite the fact that syringe access is not more widely available in the state of Pennsylvania yet, because we have syringe access, because we have access to testing, because we have providers in Philadelphia who are willing to treat drug users and respect and treat them where they're at and apply a harm reduction-based model, we've really seen the number of new infections related to drug use come down quite significantly. So that when we look at our total number of infections in a year, drug use only makes up about 5% of new infections in a given year. So that's a tremendous success, and I think it shows that applying a harm reduction approach really does work. But if we only looked at new infections as a metric of success, I think we can miss potential new infections, and I think we can miss other harms related to drug use. So I think data is a huge point that health departments can consider when it comes to considering what does drug user health look like in our jurisdiction. So how can we get a broader picture of what's happening around drug use in our areas that we work in? And so if you go to the next slide, you can see that if you look at hepatitis C data, for example, what we have been seeing since about 2011 is this emerging epidemic of hepatitis C among younger people. So traditionally, hepatitis mostly affected baby boomers who had been infected for maybe several decades, and that has primarily been where our case reports were coming from. That started to change in 2011, so that by 2015, we started to see a bimodal curve in our new hepatitis case reports. So that, and this was primarily driven by drug use. So we looked at that and we shared that with our colleagues in the health department, and I think it shows the importance of collaborating across health department areas to see where emerging trends of disease related to drug use may be happening. And hepatitis C is clearly an early indicator of where pockets of infection might happen and can help prepare us so that we can prevent, hopefully, an HIV outbreak from happening. And if you go to the next slide, I think, of course, it's also very important to look at deaths from overdoses. Philadelphia has one of the highest overdose mortality rates of any major city. We lost 1,200 of our residents to an overdose last year, and that's more deaths in 1 year than at the peak of HIV in 1994. So even if drug use isn't driving new HIV cases, all of this goes to show that there are clearly other health outcomes that are on the rise because of drug use. And they affect people who are living with or at risk for HIV. So when thinking about the role that HIV programs can play in addressing drug user health, I went back and I took a look at a document that our city put together last year, which was our Opioid Task Force recommendation. So if you advance 2 slides, I think that our task force recommendations provide a nice framework that can help HIV programs think about how they can address drug user health. And I think along with this, the fact that we had a mayor and a health commissioner and other city leaders who were willing to convene stakeholders from both in-city agencies and external partners, I think that buy-in from the top was really critical. Prior to this task force being convened, there was a task force that our syringe exchange program had convened that the health department did participate in. It was much smaller, much more grassroots. And we had developed a list of strategies to address the opioid crisis. But it unfortunately didn't make much traction until the mayor decided to kind of take that grassroots group and expand it and put some higher level people on the task force. And we're very grateful that he did do that because it really did elevate the issue of drug user health in the city of Philadelphia. It did get more resources put behind it, and it did start to see action on a lot of these steps that were recommended. And so monitoring and evaluation was one of the the things that affects all the other components of the recommendations, because you need to have a baseline understanding of what's happening around drug use in the city and then be able to measure any progress towards it. So things that our HIV program have contributed to related to monitoring and evaluation is we have a cross-departmental overdose outbreak response work group. So we bring people together from hepatitis and HIV and emergency preparedness and other areas to, figure out what our response would be if we started to see an outbreak of HIV among drug users. And part of, the data response as well is matching data across program areas. So matching HIV and hepatitis data, matching infectious disease data with overdose data. And I think that having ongoing ways of collecting feedback and information from stakeholders is also critical. So an example of something that we've learned specifically on the project I'm working on is what are barriers to care for people who are co-infected with hepatitis. And one barrier that we've seen emerge is that when our DIS folks are going out to do care engagement activities and are bringing people into the clinicians' offices, if a person who is an active drug user has to sit in an office for several hours before they can see a clinician, oftentimes they're going to leave before they get seen if they start to have withdrawal symptoms. So even though we have some great providers who are harm reductionists and treat drug users, I think that needs to trickle down to even the frontline staff, so that if someone who's a drug user presents in a clinical setting, that staff from the front desk onto the clinicians know how to work with them so that they can be retained in care. And so I think quantitative and qualitative data is really important in our response to drug user health. And if you go on to the next slide, we have prevention and education and treatment. And I think as far as these things go, HIV programs can lead by using person-first language. So we know that we say people living with HIV, not people suffering from HIV or victims of HIV. And it's similar with people who use drugs. Avoid saying words like addict or junkie that can be stigmatizing. Health departments can really lead and help destigmatize drug use by using person-first language. I think thinking holistically when we create programs and materials, so we're not just addressing HIV or hepatitis, but that we're creating targeted materials that have integrated health messages, and encouraging providers and frontline staff to incorporate harm reduction messaging into their work, providing trainings and opportunities for people to become more familiar with harm reduction, so that they can consider what that would look like at individual HIV service sites. And it can look very different depending on the resources a program has available, from getting their staff trained in naloxone and carrying naloxone, to prescribing naloxone to their clients, to providing on-site medically assisted treatment for clients in some of our clinical settings. And I think knowing what these best practices in our jurisdictions are and being able to promote them is a key thing that health departments can do. And if you go on to the next slide, it kind of continues along with those sort of activities, thinking about overdose prevention and involvement of the criminal justice system. And so, again, I think that, understanding what's working and promoting those best practices, and trying to expand harm reduction services as needed depending on the scope of drug use in your jurisdiction. And so to close, I think that when I think about my work in public health and staying motivated, I think that if we look back on the history of HIV, we can draw a lot of lessons that we can apply to today's opioid crisis. And I think that we can find inspiration in our work that can help, I think, reinvigorate us and re-inspire us and ground us in the work that we do. And so I think if you look back in the history, if you go on to the next slide, or actually the slide after, social and racial justice is a really critical piece of what we do. I don't think we can talk about drug user health without acknowledging and addressing the impact of racist drug war policies. The Harm Reduction Coalition created a North Star statement that I think does a really good job of, and if organizations read this, I think it does a good job of saying, we need to look to what happened in the past. We need to prevent it from happening again. And we need to look at where racism exists in our systems so that we can really, and we cannot address the opioid crisis. We cannot address drug user health unless we look back and acknowledge the past. And in a city like Philadelphia, where heroin is not a new issue, this is definitely something that we see coming to play when we're talking about things like supervised injection sites. People think we criminalized drug use for a really long time, and now we're talking about it as a public health issue because it affects mostly white and suburban populations. But what about when it was affecting Black and brown people in our community? And that's a true thing that we have to grapple with and deal with and have a conversation about if we want to advance harm reduction services beyond syringe exchange and think about things as bold as safe consumption sites. And I think that on top of that, if you go to the next slide, community mobilization and activism is how we built this incredible HIV system, and it's how we're going to overcome this opioid crisis and reduce the tide of deaths and poor health outcomes from the opioid crisis. We see people marching in the streets today, much like they did 30 years ago, fighting for better services, fighting for justice, and fighting for marginalized people whose lives are too often forgotten, and too many people see some of these deaths as disposable. And I think the HIV community lending their voice to this fight can be really powerful because we've seen what an impact that made 30 years ago in improving public health services. And finally, I recently read this really great piece in the New England Journal of Medicine that talked about fighting burnout among medical providers specifically, but I think it has words of wisdom for people who work in community settings or in health departments as well. And it's a reminder that being part of a community of advocates empowers us to fight for solutions to this crisis. I think it's a reminder that there are a lot of upstream battles that relate to our areas of public health, and we will only make headway if we come together as a community and have the support of health departments and our community partners and government officials, and just trying to find ways to build community as we're advocating to improve access to drug user health services. So that's kind of a very broad look at what we're doing in Philadelphia and some of the approaches that we're taking. And so hopefully some of it's helpful, and I'm happy to talk more about some of our strategies in the discussion portion.
Thank you so much, Alex. I really love several things you said and wanted to pull a couple things out. So the first was where you were talking about how HIV can be an indicator for hepatitis C, which is an indicator for overdose. And we see that working backwards as well, right? Overdose can be an indicator of hepatitis C, which ultimately can be an indicator of HIV, which is something that we saw in the Scott County outbreak several years ago, and was something that was also highlighted in the CDC vulnerability index when they reported that. So I really wanted to pull that out. And I also really like how you all are utilizing a cross-departmental work group to be able to work across silos and comprehensively address the needs of folks who use drugs. And one thing that led to then is you describing a couple of best practices, which I think were completely on point. And one thing that I wanted to add to that, especially, I live in Seattle right now. I'm on the West Coast, and I grew up in the Southwest in Colorado, which is where I injected drugs. And their methamphetamine use is incredibly high. Same with here. And so I think that it's important to not make everything so opioid specific, because we need people to be able to see themselves reflected in programs, which is something that you highlighted, right, when you were talking about the North Star statement that Harm Reduction Coalition just put out, is that when folks of color are going into syringe access programs, when GLBTQ identified folks are going to syringe access programs, if they don't see themselves reflected there, then they're probably not going to be coming back, right? And so we need to be able to have sensitive services for those folks. And so then to add to that list, I'd say too that to make sure that we are kind of comprehensively serving all people who use drugs. A lot of times now we have a huge focus on the opioid epidemic, which is really important And so just wanted to put a little like West Coast plug in there. So thank you so much for that. That was really amazing. And then one other thing I just want to pull out, this is me just kind of summarizing, being really excited by everything you just said, but you really highlighted how harm reduction is at the intersection of public health and human rights. And so our public health programming is informed by the grassroots activism that is happening on the ground and vice versa, right? Our data and our programming can feed into the activism that's happening on the ground, the advocacy that's happening. And so really we need each other and we play really well together. So thank you so much for that. And we're going to move on to Gail's presentation next, and then we will have a period where we can all ask questions of both Alex and Gail. So with that, Gail, I'm going to turn this over to you.
Thanks, Magali. I appreciate it. Hi, everyone. Thank you for having me present to you today. I think that's sort of the middle of my presentation. So yeah. Okay. So just to reiterate, I'm Gail Goldstein. I'm the Senior Director of Planning and Programs in the Bureau of Alcohol and Drug Use Prevention, Care, and Treatment at the New York City Department of Health and Mental Hygiene. And I'm going to talk to you today, if you can go to the next slide, please, about sort of give some context for New York City and our overdose data, what we've been doing in terms of a public health response to the opioid crisis, and a little bit about overdose prevention centers, also known as supervised injection facilities. Next slide, please. So for context, next slide, please. So New York City has more than 8.6 million residents. It has 5 boroughs, which are also 5 different counties, most densely populated U.S. metropolitan area, ethnically diverse, very large income disparities, and a history of redlining and residential segregation, which remains quite significant today. Next slide, please. So talking about overdose in general, you can see this is our data since 2000. And in New York City, there was actually starting to be a dip in overdose deaths around 2010, and then started to steadily increase once we think really the prescription opioids entered the world. But you can see in particular this huge jump between 2015 and 2016, where there was a 50% increase in overdose deaths. That epidemic level has remained steady from 2016 to 2017. Next slide, please. So when you compare that to the national data, you can see that the blue line, which is the national data, on the left, that's all overdose deaths, and on the right is those just opioid-involved overdose deaths. But you can see that the blue line, which is the national rate, has been sort of steadily increasing across the country. Whereas in New York City, it's been much more nuanced. There's been ups and downs. And you can see that towards the end of the graph on the left in 2016, our rates unfortunately shot up to meet the national rate. When you look at the opioid-involved deaths on the right, again, it was a little different, different ups and downs than the national rate. And we think that we, because we're New York City and you know, obviously are much smaller than the entire nation, we're able to identify the opioid deaths a little bit more accurately. And so we think that perhaps the national data is missing some opioid-related deaths. Next slide, please. So this huge jump that we saw between 2015 and 2016, we have attributed to an increase of fentanyl in our drug supply. Prior to 2015, there was only about 3%, fentanyl was found in only about 3% of our drug overdoses. And then it jumped up to 50% of our overdose deaths are fentanyl involved. So you can really see that the opioid analgesics actually are fairly low, and I think lower than the national average, but heroin and fentanyl have really driven this increase. Next slide, please. So this is a map of New York City and all 5 boroughs, and you can see that the dark blue are the highest rates of overdose deaths in the city, and those are found in the South Bronx and in Staten Island. And we at the health department use this map all the time to sort of map all of the disease and more, morbidity and mortality across the city. And most frequently, we find that the communities with the lowest resources, highest percentage of people of color, tend to be the ones in the very dark blue. This epidemic is a little bit different because the Staten Island is not a particularly low-resourced or borough with a lot of people of color, but you can see very high rates. But what we really try to point out is that the South Bronx, which has always had overdose deaths rates that have been skyrocketing since the 70s, have many more deaths. So we really look at rates, but we also look at numbers. And the South Bronx, being a very large place, has rates sort of comparable to Staten Island. So we're really focusing on looking not just at the rates, but also at the numbers. Next slide, please. So I'm going to talk a little bit about how we're responding to the crisis. Next slide, please. So in March of 2017, the mayor announced HealingNYC, which is our comprehensive opioid response strategy. There are 14 strategies involved. It's a collaborative effort across multiple New York City agencies. Next slide, please. So the health department got a portion of that $60 million you saw on the previous slide. And we have some key activities that I'm just going to highlight here. And the first is to really change health provider opioid prescribing to prevent overdose and addiction. That mostly took the form of a detailing campaign where we would go out and talk to providers about judicious prescribing of opioids and provide recommendations. Next slide, please. We also did a lot of targeted information to reduce risk, particularly around fentanyl, and to highlight among people who are using drugs that fentanyl is out in their drugs and has hit the New York City drug supply. And one of the things we've mention is that we are finding fentanyl not only in opioids, but also in lots of other drugs, including cocaine and methamphetamines and pills that are sold on the street. So we're really trying to get the word out. It's not just heroin that you can find fentanyl in, and you could be overdosing when you don't think you're using an opioid at all. Next slide, please. Another key strategy is to get naloxone kits out to as many people who are at risk as possible. This slide really shows our efforts to increase our naloxone distribution. And you can see from 2016 to 2017, we quadrupled our distribution. And the pink bar is showing 2018, which is half a year. So we're really pleased that we were able to get out so much naloxone and anticipate doubling what we did last year. Next slide, please. Another one of our key strategies is our relay program, which is linking individuals who have survived a non-fatal overdose to naloxone and ongoing care services. So we actually send peers, who we call wellness advocates, to emergency rooms to connect with someone who's come in with a non-fatal overdose, provide risk reduction messages, give them naloxone, and offer referrals. And then we follow up with them for up to 90 days to really use this engagement point to try and provide some services and prevent another fatal overdose. Next slide, please. In addition, we are putting lots of effort into increasing access and use of medications for addiction treatment. Here you can see we are working on stigma around methadone and buprenorphine with our Living Proof campaign, which was on TV, on the subway, on buses, social media, that talked about people telling their story about how medication helps them. In addition, we're also doing training of physicians to prescribe buprenorphine and offering technical assistance to physicians in primary care to implement more buprenorphine, in substance use treatment, and in a syringe exchange program. So we're really trying to get at all the places that people might be engaged. Next slide, please. So I just wanted to take a quick minute to talk about overdose prevention centers, which is what we have labeled supervised injection facilities here in New York City. Next slide, please. So for those of you who aren't familiar, supervised injection facilities are hygienic spaces supervised by health care professionals where people can use pre-obtained drugs, receive education and equipment, and connect to essential health and social services. These sites have been working for over 30 years worldwide, not in the United States. And there have been lots of studies of SIFs and that demonstrate that they reduce overdose deaths, reduce public drug injection, do not increase drug injection or crime, attract people who are not engaged with other essential services, and results in increased use of primary care drug treatment and can save healthcare and criminal justice costs. Next slide, please. So we really look at this, we really look at safe injection sites with an eye towards the history of getting syringe exchange programs up and running in New York City. Both are harm reduction interventions with similar histories. Both have faced and continue to face strong opposition, and yet often supported by people who use drugs, advocates, and the medical scientific community. Next slide, please. So there's been a lot of work in New York City, a lot of conversations around supervised injection facilities. A community coalition called SIFNIC was formed in 2015 to really advocate for supervised injection facilities in New York City. And New York City Council awarded $100,000 to our department to conduct a feasibility study. Next slide, please. So we did this study along with the New York Academy of Music, and we did basically lots and lots of focus groups and interviews with key stakeholders. We interviewed over 71 key stakeholders and held a number of different focus groups. Next slide, please. Lots of concerns were raised that SIFs could be perceived as condoning drug use, creating geographic concentration of people who use drugs, putting people who use drugs at the risk of victimization, and creating drug market opportunities, many of which have actually been borne out or shown that in studies of SIFs are not things that actually happen. There was a great deal of support, and we were pleased to hear that that support was sort of across the board. I mean, even people in law enforcement were expressed the feeling that if this could help save people's lives, we need to think outside the box and see if it can work. Next slide, please. So we also engaged Weill Cornell Medical College to do a mathematical model about looking at our data and literature to estimate the lives and costs that would be saved. For one SIF, it could prevent between 19 and 37 overdose deaths annually and save approximately $1 million. For 4 SIFs, it goes up exponentially from there. Next slide, please. We also had a Columbia Law professor do a review of relevant federal, state, and municipal laws and found that there is a path, and it does require the state, but it can be done with a state administrative action. Next slide, please. So in May, our mayor, de Blasio, announced support for overdose prevention centers in New York City after the release of that report. And it recommended 4 overdose prevention centers in 3 boroughs, co-located with existing syringe exchange programs. It requires a state health department authorization for a research pilot and approval of local district attorneys and council members. It would be funded with private dollars and would involve a 6 to 12-month period of community engagement. And once that state authorization is granted, the pilot sites can begin to establish operations and guidelines. Next slide, please. So that's where we are with the overdose prevention centers. The announcement was made and the report was issued, and we're have not heard yet from the state. And that is my presentation. Thank you.
Thank you so much, Gail. It's really exciting to hear about all the amazing work that is being done in New York City. I'm always excited to hear about it. New York City is just such an innovator. And one thing that I think is really evident from across both your and Alex's presentations is that overdose prevention is and absolutely should be an HIV program priority. And that's something I think that was really present in today's conversations. And I really like how you both also had highlighted that fatal overdose is highest among communities of color. And Gail, you were really able to show that in your presentation. And you all are doing some really great innovative things, such as addressing stigma as a barrier in buprenorphine access and other places, which of course is something that really gets in the way a lot of times. And so working with providers is something that's really necessary to be able to reduce rates of overdose and reduce rates of infectious disease among the people who inject drugs in this community. And also really being able to utilize peers, which is something that across the board, I think New York City has always done well. You have a robust peer network that is able to work in syringe access programs, etc. But being able to have peers provide naloxone and referrals in in emergency rooms post-overdose is a really brilliant way to be able to reach people and utilize peers in a way that is mutually beneficial and hopefully contributes to the end result of folks being able to have the tools they need to reduce overdose in their own lives and their own community. And then also, it's really exciting to hear that, first of all, I think overdose prevention centers instead of supervised injection facilities is probably way more palatable, and that 4 are being recommended moving forward. And I think one of the things that you all did in there that could be perhaps adopted in other urban centers that are trying to advance overdose prevention centers and safe consumption sites is doing a cost savings, because that seems like a really powerful tool and can appeal to a bunch of different political stakeholders from across the aisle and bipartisan stakeholders. So thank you so much for your presentation. And so now we're going to open it up for questions. And for folks who have questions, if you want to go ahead and type in the right-hand side, you'll see the Zoom group chat, and you can type your questions there. And I have a question to kick us off, and so I'm going to ask Alex and Gail, but then also if other people want to answer for your own program, you can also type answers as well as questions into the chat box here. And so I feel like you all answered this question a little bit, but I really wanted to kind of ask it directly to hear more from you. And so that is that ever since the HIV and hepatitis C outbreak in Scott County in 2014, CDC has been really focusing on the vulnerabilities of rural communities to HIV outbreak because there's not a lot of public health infrastructure. But overwhelmingly, what this has meant is drawing attention to the fact that, according to CDC studies, more white people are injecting drugs than any other race, and we really need to be able to flood kind of poor white communities with resources. But some people argue that that's at the exclusion of folks of color in urban areas, right? Because there's only so many resources, and now we're shifting them away from where overdose and HIV and hepatitis C have always been highest and have always received a different response, right? So now when it's like for white people, there is a kinder, some say a kinder, gentler response in the form of treatment access and diversion programs, whereas in communities of color, there's mandatory minimums, inflated sentencing, and like high rates of incarceration. And so my question for you all is, how is your program trying to navigate this and center the needs of people of color or in your drug user health program?
This is Gail. I can go first if that's okay. So this is something that we've been really thinking about a lot in New York City. And our health commissioner actually, about 2 years ago, really thinking about racial equity in general and how it impacts health, started an agency-wide project called Race to Justice to really look internally at the health departments and the way we operate, and if we really put racial equity at the forefront of our activities, not only as in hiring the people we hire here and how we operate and internally, but also thinking out externally. And it's been a really amazing process to learn about racial equity and all of the complicated issues to try and reframe the way we all think. And we've all been encouraged to bring that to the work that we do. And so we've been trying to use a racial equity lens in the way that we sort of think about the way we operate in general and apply it to the way we've been working in the past. And so one way we've done this is to start thinking about our contracted treatment programs. So we work with about 100 treatment programs in New York City. And we meet with them every year, and we've been starting to teach them about racial equity and sort of bring the issues of racial equity into our annual meetings. And just had a third meeting with this as a topic. So we're trying to sort of introduce the concept. One of the things we learned is people don't really understand what we're talking about. You sort of have to start at the beginning. I think this is in some ways a lot of a new concept for people. I mean, everybody knows about racism, but racial inequities can be confusing. We have to pull out that picture of the fence with the three people who can't see over the fence. So we've been doing that. We're trying to integrate it into the licensing for all the treatment providers in the city as well. And then we really focus on the who's getting resources in New York City. And while we're certainly addressing high rate, as I mentioned, while we're really focusing a lot of energy on places where there are really high rates of overdose, we really are trying to look at the impact that overdose has on communities of color and communities that are under-resourced. And we tend to focus all of our resources to the places with the highest rates and highest number of overdoses. So we really keep both numbers in our minds as we make decisions moving forward.
So I think that the work that New York City is doing on that is really amazing. The point I have to add, I think, is understanding the stories behind the numbers and the data, and I think that speaks to the importance of partnerships with organizations in the community. So, when you look at our drug use data, in some metrics we see that Latino individuals are disproportionately affected and have some higher rates of overdoses, and is one population that is particularly our Puerto Rican population that is very affected by drug use in Philadelphia. And the story behind that is that there had traditionally, before the hurricane, been something called the Air Bridge, where these recovery homes in Philadelphia were promoting themselves, unsanctioned recovery homes were promoting themselves in Puerto Rico, and families were paying money to these recovery homes and sending their family members who were drug users to the United States for treatment. And some of these recovery homes were known for taking advantage of people and taking checks from them and providing substandard services. And so folks would end up out on the streets and homeless. So we had this population of Puerto Rican homeless drug users. And that was stories that came out of working with our syringe exchange program and doing surveys and having services that targeted this population. So I think when we look at our data, like what is the story, what more is there behind that? Because that's obviously then becomes a situation that needs to get addressed on a local level, but then there's also these like other political issues that kind of come into play. And so I think that's where our partnerships with the community are really valuable here in Philadelphia. I think that what New York City pointed out as far as the overdose prevention sites is the community engagement and tying that piece in from the very beginning, even before that announcement is made. So earlier this year, Philadelphia also announced support for what we're calling comprehensive user engagement sites, or CUEs. And so a very similar structure, the city would not pay for these sites, but would support private entities that would come in and fund sites that were essentially supervised injection sites. I think we have learned since then that engaging the community prior to that announcement would have helped, because when we've done some community forums, a lot of the pushback has been around the fact that for a long time we criminalized drug use, especially when it was Black and brown communities. And while people, I think, do understand why we're taking a public health approach, there's still a lot of anger. These communities are still very much affected by the war on drugs. They still see those harms play out. And so I think that community engagement from the start, having those conversations prior to an announcement being made, is really critical. And the final point, I think, is just also the importance of voting and politics in this. We have a very progressive DA who was voted into office last year in Philadelphia, who has shown his support for the CUEs and has shown his support for syringe exchange services. And we are in a state that does not support more widely syringe exchange programs. So I think it shows that, the role our community partners can play is trying to get support politically for harm reduction services, asking people who are running for office how they plan to support drug user health initiatives. And I think our community partners can help mobilize folks to register folks to vote and help bring in candidates who are going to support public health oriented strategies to address drug use.
Great, thank you both. It looks like we have a question from the participants here. So this question is for both of you. What we are seeing here is actually a syndemic of HIV, hepatitis C, and overdose deaths. It is obvious to me, as your presentation indicates, we need to break down the silos and develop greater integrated programming. However, clearly DPH cannot do this alone. So how do the local DPH utilize the power of CBOs to gain greater traction in communities who use drugs, who do not always trust the Department of Public Health?
So I think what helped us in Philly is that when I was working primarily on hepatitis, and we started our Hep C Allies of Philadelphia, or HepCap Coalition, and that coalition was started around the time the new Hep C treatments were coming out, and we had access issues, and our deputy health commissioner came to those meetings, health department leadership came to those meetings, and so I think that having leaderships there in the room who saw and heard from our community partners and heard what was going on, and also in those coalition meetings hearing about drug user health and the emerging hepatitis C in drug users in Philly, I think having those leaders in the room and putting this on their agenda is really what helped prioritize drug user health in Philadelphia. Again, we've had a heroin issue in the city for a long time. It's not a new issue. Fentanyl made it a much deadlier issue and really changed the game and led to the spike in overdose deaths. And I think regionally, prescription drug use leading to heroin use also did bring a lot more suburban users into the city. And so I think that because drug use, though, had been an issue for a long time, unfortunately, I think that we had become kind of lax in our response to it. But when we had leaders in the room who were seeing the data and hearing from our community partners, and us helping facilitate meetings between our partners and health department leadership, I think really helped get those leaders on board to recognize that this is something we need to prioritize a lot more. So I think health department mid-level officials can help play that role by finding opportunities to bring together our grassroots partners and leaders at the top who are maybe more of a place to push change forward.
Yeah, so I would say that we certainly really try to maximize the relationship that the syringe exchange programs have with drug users, and have really worked very closely with the 14 syringe exchange programs in the city to try and get messages out, and to, gain the trust of the people who use drugs in New York City. All of those 14 syringe exchange programs are also funded by our HRV programs and Hep C programs, and we do work in a somewhat, although probably could use more, integrated manner with those programs. We all fund the same people in terms of the syringe exchange programs, and really try and think collaboratively about how to maximize the resources that we're providing. And have even started to think more broadly about, who's giving out, for example, as I mentioned, one of our major mechanisms of addressing overdose is getting naloxone out, and we do that. We used to do that primarily through our syringe exchange programs, and they're now not primary. We have expanded into so many different types of community-based organizations working with HIV and Hep C programs to sort of identify their partners and beyond. We work with homeless programs. We work with the housing people. We really try and think really broadly about anyone who might possibly interact with someone who is at risk for an overdose or knows someone at risk for an overdose, to get naloxone into the hands of people who could save someone's life. So I think it's a great point that we need to use that, the CBO relationship. And we are, really trying to think outside the box about how to get, sort of out of our silo.
Our next question also comes from the participants. It says, are any health departments working with their local law enforcement offices, so this could be police or prosecutors, on the impact of police profiling of people of color around drug use, the impact of nonviolent drug-related detention and incarceration of individuals, and the effect this separation has on families, and initiatives for those currently going through the justice system around drug user diversion programs instead of incarceration? It's a big topic. Great question.
In New York City, we actually are working really closely on most of these activities. Several years ago, prior to myself joining this program, people here established something called RxStat, which is a collaboration between public health and law enforcement and criminal justice. It's an attempt to share data and to really share approaches and to really use public health to influence the way law enforcement interacts with people who use drugs. And we found it to be a really amazing partnership. We still get frustrated, of course, but there's been a lot of change in the way I believe law enforcement and criminal justice think about drug use and people who use drugs. And it's been a pretty effective mechanism for having that conversation. There are a number of different types of diversion programs happening in New York City right now. There was one started over a year ago in Staten Island by the Staten Island DA in collaboration with a number of nonprofits and various CBOs and hospitals and treatment providers, and we were a part of that advising. That's actually been pretty successful, and now the rest of the district attorneys in the other 4 boroughs are, 3 of them are developing or have implemented similar programs, which we're really excited about, and we're really, happy for that collaboration and are the voice of reminding people, the goal is to not incarcerate people who have a problem with drugs. So that's been pretty successful. And we also, there's also have been work in New York City where the police have certainly reduced their arrests based on marijuana and various types of low-level drug use and drug possession.
Philadelphia, I think, has looked at New York's RxStat model, and I think are thinking of how to apply that here as well. And we're already sharing data back and forth between the health department and police. The health department has provided, is the main provider of naloxone to our police department. And I think that around this issue, we are seeing more diversion programs. We are seeing more of an emphasis on the warm handoff and trying to make that link from people who may come in contact with the criminal justice system, and instead of arrest, diverting to treatment options. Not all of addiction services are under public health. We also have our Department of Behavioral Health, which oversees the Office of Addiction Services. So I think they do a lot of collaboration on criminal justice related programs, working with the DA and the police department. But I do think the task force helped bring a lot of those stakeholders together in Philadelphia a lot closer than they ever had been. And again, just reiterating the fact that we had a DA come into office this year who really does understand public health and is using his office to try to have a more public health oriented approach to criminal justice, and applying that in a very broad way. And we also had a MacArthur grant that we've had for a while. I believe it's MacArthur, to reduce the daily prison population. So there are a lot of criminal justice initiatives that had already been happening in Philadelphia. And I think that now the health department's trying to figure out how we can engage more proactively with some of those programs that are happening.
Thank you both. It's really interesting to hear about some of those programs. And I see here that Paul Harkin also mentioned the Law Enforcement Assisted Diversion Program, and I've actually done a lot of consulting on that program, so thought I would talk a little bit about it. So Law Enforcement Assisted Diversion, or LEAD, is a harm reduction based pre-booking diversion program. So before we had pre-booking diversion programs, really the only options that folks who had police involvement around their drug use had was either to go directly to jail and probably prison, or to go to a post-booking diversion program, which is mostly drug court, which is based on a very kind of like white upper middle class idea of success. And drug court, I know some people who really attribute their recovery and even their life to drug court, but we really need more options for people who use drugs. And so this really took that into account. And what it does is when police interact with someone who has drugs, and it's usually a low level amount, so enough for substance use or substance selling, then they are referred to a case manager who works on whatever goal it is they want to achieve. All they have to do is an intake and their charge is dismissed. And this is very different than drug court, where you have to take a variety of different classes, a variety of different drug testing, and you have to stay abstinent in order to succeed. And with drug court, if you don't, then you get a running or absconding charge on top of the charge that you originally had. So this is why this is really great. And then on top of that, it's really the only program we know that is harm reduction based. So folks don't have to stop using drugs in order to be considered successful or to get their charge dismissed. And they're actually, if you go to Lead King County, I'll actually type it here in a second into the Zoom chat. If you go to leadkingcounty.org, you can see a bunch of the different evaluation reports that showed that it increases access to housing, reduces recidivism, and I've been trying to work with folks here to try to get some infectious disease data to see if LEAD does reduce infectious disease, or kind of the word is still out to see if it has reduced racial disparity, but that's kind of the next round of evaluations. And this is why I think it's so important for health departments and infectious disease prevention and care programs to be involved in these criminal justice reform measures, because then we can have evaluation to show the efficacy all the way across the board, because we know the war on drugs has horrible public health consequences, but can we show that criminal justice reform has better public health consequences, or is helping us back our way out of that? So thank you, Paul, for drawing attention to LEAD. I think it's a great program as well, and is being started in many urban cities right now. So something for folks to look into. Do we have any other questions for folks? And while folks are typing, I had one that I think folks have addressed a little bit, but wanted to draw out a little more, because in my time at NASDAD, when I was working with a lot of health department professionals, we would talk about breaking down silos. And I think that there, a lot of times, was a pretty good connection and relationship between the community and the health department. But then when it meant going to work with partners in drug and alcohol prevention, or in overdose, or any sort of violence prevention and control, a lot of times those departments are across the city, right? And so we'd say, okay, start a cross department work group, and a lot of times folks would be like, I don't even know how, right? Like, I can just write an email and I don't know who it goes to, and that just doesn't seem effective for me. So I'm wondering if we could go back to the beginning and start to talk about some of the minute details of how to form those partnerships across sectors and across silos, please.
I mean, I think just on a very basic level, there's a lot to be said for the coffee meeting. And if you find yourself in the same room with someone and you can see that opportunity for potential overlap, or meeting someone who could be an entry point into a department that you've had a hard time connecting with. I mean, just sitting down individually, one-on-one, and getting to know who people are and what they do. I mean, I think that plants the seeds for larger collaborations moving forward. So I think that's more of an internal, like, grassroots type of approach. I think that, having leaders, either the health commissioner or department leaders, or even higher up in the city, convening groups like the Opioid Task Force, or having our HIV director kind of help convene a outbreak response strategy. I think making sure that those folks know to include diverse participants. And so if you consider yourself the harm reduction champion in your health department, make suggestions of who to bring to the table. And if you're not that person, ask that person, hey, we're having this meeting to talk about drug user health. Who else do you think should be in the room? And so, I mean, so much of the work we do is just about building relationships, which does take time and it does take effort. But I think if this is an issue that you care about, making sure you're the person who has contacts and relationships. I've seen how I can help play that role in my health department by just knowing who the folks to bring to the table can be, and try to help foster relationships and kind of be a bit of a matchmaker.
Yeah, I'm the only other thing I would add to what Alex just said is that one of the things we've noticed is that everybody's interested in naloxone training. Sort of across the board, people have been people we couldn't get in the room with all of a sudden when they say, oh, well, I could come do a naloxone training, they get very interested. We do make a point when we do trainings to say, please, feel free to come take a kit if you think you're going to, if you'll need it. If you know someone, you think you'll be around someone who might be at risk of an overdose, if you will be. But we've been invited by judges, by courts, by probation, all sorts of places that might not have been interested in having a conversation with us beforehand, and that has really led to some great collaborations.
Great, thank you. And I'm not seeing any questions from participants here, so hopefully those are getting to me. But I'll ask one more that is something that I always have on my mind and am interested in, and I'm really glad that you both seem to be addressing in your jurisdiction. So wanted to ask this question, and that's that I think that the leadership of folks who are current or former drug users is really important across this entire process. And we see a lot of that on the community level. And my question is, how can we start to create more opportunities for that within governmental public health? There can be a lot of barriers because folks have criminal records, etc. And so I'm wondering what you all are doing on the governmental public health level to make more leadership development opportunities available, or to leverage the leadership of people who inject drugs, who either currently inject drugs or formerly, or even ideas of how to make that happen. Thank you.
One of the strategies that I touched on but didn't really fully talk about was all the stuff we're doing around peers. So I mentioned the relay program where we have peers who go to the emergency room. So we have hired a cadre of peers to do this work both full-time and part-time, because it's we have to have 24/7 coverage. So we have a lot of people hired. And so that has really changed the tenor on some level of the conversation in our bureau, which has been a great addition to really inform the work of all of our work. It is emblematic of the work we're doing to promote peers in general. So we've been providing sponsorships for peers to get certified so that they, with the state certification, so that they can provide services that will be billed by Medicaid and therefore will be integrated into treatment programs. We are providing technical assistance to treatment programs to get peers on board. There already are many in syringe exchange programs, but in treatment that has been a real barrier. So we've been really promoting that. We have been thinking about, sort of the peer workforce and how that, how to provide people an opportunity. And as I said, Relay has been one way to really integrate a lot of people into our work, but we're really trying to think about where peers could work across the board. And we also have, we do actually have people who have experience using drugs who are, not working in the Relay program as well, who work across the bureau. So we're constantly thinking actually about how to do an even better job of integrating people with lived experience.
Yeah, in Philly, particularly just my space of public health, which is hepatitis, I think that New York is doing a lot of fantastic work on a lot of different fronts with peers. I think that New York's a very well-funded health department, and sometimes I think what can be frustrating for smaller health departments or ones that don't maybe get as much city or state funding is sometimes the resources to do peer programs. And hepatitis, we've seen that as far as linkage to care goes for hepatitis treatment, peer engagement can have a huge impact on helping people get from testing and make it through treatment into a cure. And so it's something that we are very much interested in and would very much like to do more around. I think that often that data comes out of pilot funding that then isn't really expanded or broadened to fund more programs like that. And so, I think getting data from places like New York or other pilot studies and trying to kind of leverage that to get more resources for peer support is something I think we're definitely interested in doing. And in the meantime, I think without funding to have as robust a peer support program as we would like, making sure that people with lived experience are involved in meetings and that their input is being considered, and that as we're developing programs, they're being developed with the input of people from the field is really critical. And somewhere that I've seen that happen is when we've had our community meetings to talk about comprehensive user engagement sites, the testimonials that are often the most powerful in the room are from people who have a history of drug use, who are willing to share that story and talk about the impact that that sort of program would have on them. And so I think that just making sure when we're developing strategies that they have to involve that input.
That's exciting to hear. Thank you all. And it looks like we have another question from the participants. So this question is, I'm sure you're aware that Canada, particularly Toronto and Vancouver, have really led the way using civil disobedience to create opioid prevention sites that are low cost with a high ratio of peers to professionals. Also, they have essentially rolled out prescription heroin. And this person believes that we need more peers. Oh, I also believe this. Thank you, Paul. That we need more peers front and center, and we need prescribing of opioids for folks with opioid use disorders. What are your thoughts on continuing to push the envelope of harm reduction services?
I definitely recommend that health departments, if they can, send staff to attend the Harm Reduction Conference, which is held every other year and is happening this year in New Orleans. As someone who considers themselves a harm reductionist in the health department, I kind of try to be a bit of a rabble rouser when I can and present those sort of ideas and facilitate those sort of conversations internally. It does also take a lot of work, I think, externally of our partners pushing the health department and challenging us to think boldly and think about initiatives like a lot of the stuff that Canada has done. There's also a book called Fighting for Space that just came out this summer, and that details what grassroots organizers in Canada did to organize and try to push for those services to open up. But again, I think the Harm Reduction Conference is a great space to learn more about what's happening, network with folks across the country, get inspired, and it's definitely one of the favorite conferences that I attend, and always come away inspired and with new ideas that I try to bring to the health department.
I would really concur with everything that Alex said. I was, you might have heard at the beginning, I came from another part of the health department and I didn't know anything about drugs, and I worked in chronic disease and on tobacco, where there is, they don't talk about harm reduction in tobacco. And I really had to learn these concepts when I got here and really change my whole mindset. And I think that most people in health departments need to do that. And we're constantly pushing the envelope here. And I think that those recommendations that Alex gave were great. The Harm Reduction Coalition Conference is really a great place to go and to learn about these concepts. And I think we might be sending some people this year, so we're excited about that as well.
Great. Well, I look forward to seeing you all there. I think that this has been a really wonderful panel and a really good primer for the rest of the day. So with that, I am going to pass it back to Jeffrey.
Okay. All right. Thank you, Magali. Thank you, Gail. Thank you, Alex. Very good presentation. Being from Houston, can you all hear me? I don't think I'm
Yes.
on. Okay,
Yes,
perfect. So being from Houston, where we don't have a whole lot of conversations about this particular topic, it is always good to be connected to the experts and have this level of conversation through UCHAPS. So very much appreciated. So our communities and our health departments will have an opportunity to separately discuss our activities and concerns and goals, as well as ways that UCHAPS can provide additional assistance. Kenya Hutton is going to moderate the community breakout session, and I will moderate the government breakout session. We've got several questions already pre-formulated that we're going to be considering in these discussions, and those questions are actually on your screen. So just a really quick run through: how can we institutionalize our organizational commitment to improve drug user health? How can funding decisions advance our efforts to improve drug user health? How can our partnerships and community outreach efforts help to advance drug user health? How can we engage and balance both community and technical expertise in our efforts? And then finally, what are our next steps? So in our breakouts, to allow for discussion, the lines will be open, but please make sure, be sure that your line is muted when you are not speaking. And in order to speak, we'll ask you to unmute your line. Take a moment or two now to check to see if you are muted, and then you will be assigned a breakout room shortly.
Is eerily quiet.
Hi, everyone. Hey, everyone. Hey, I'm Paul. How are you?
I'm good. I miss my peeps. I miss my UCHAPS.
I know.
This video thing's just not doing it for me.
How about?
We're trying to get it. Trying to get it together. Give me 1 second. Let me help out the folks in the other group, and I'll be right back with us, okay?
Hey, Kenya, before you run off, this is Patrick from Chicago. So I got invited to this one. Should I be in as community as opposed to health department? I'm totally game to stick around with y'all, but I just want to make sure I'm in the right place.
No worries, I'm moving to the community.
Okay.
All right.
You know where it's at, Patrick.
Jeffrey's not invited. He hasn't joined yet. Let me try him again.
Kenya, do you see Mike Wilkerson from Houston?
Let me see. No, I do not see Mike Wilkerson.
Or Crystal Townsend? Houston.
Don't see Crystal.
All right.
I'm still waiting for a few more people to join the invite. Yeah, let me try to. Oh, Kenya, if I see you guys are in here. So let's just wait a few more seconds for folks to accept the invite. Because if they didn't accept the invite, then they'll just be kind of in space. So you should be. Do you see your health department room? Okay. I'm going to unmute everyone's lines. Everyone in here is unmuted. You want to send them a message? Tell them join back? All right. Well, we're good to go. So we still have a few more people out here to come in, but we can go ahead and get started in the meantime. Let me go ahead and share my screen with my questions. All right, everyone, your phone has been unmuted, so feel free to speak whenever you'd like. But the first question we're going to ask right now is, how can we institutionalize our organizational commitment to improve drug user health? Anyone can go ahead. All lines are unmuted. I'll read the question one more time. How can we institutionalize our organizational commitment to improve drug user health?
Okay, I can take a stab.
Okay.
Health departments, I feel like they have to partner with CBOs, because just and generally the lay of the land on the ground is that CBOs that have harm reduction programs such as syringe programming, overdose prevention programs, even HIV, Hep C testing programs, but they're situated in an otherwise drug user friendly environment, are much more likely to engage those populations in the healthcare continuum, whether it's for HIV, for Hep C, or reducing overdoses, and also linking folks to drug treatment. So when you have situations where health departments don't partner, we see a fall off in participation by drug users. You see less advocacy for drug users' rights. You see less advocacy to dismantle the health disparities that exist. So really, we have to have better funding for community programs in partnership with, drug user, health departments have to partner with drug user friendly organizations. The cities that are doing well, that's what's going on. That's why San Francisco has the fewest overdoses of a big city, because they have incredible partnerships around getting the naloxone through all their community-based programming. Although I did love the presenter talking about the linking individuals who went to the emergency room who overdosed and getting connected by peers. That is fucking awesome. I think that's something that we don't do, because I feel like we have it saturated, but right there, the biggest indicator of somebody who's going to overdose is somebody who's already overdosed. So it makes great sense to have peers hanging out at emergency departments and helping folks who have overdosed to remain linked to getting naloxone and having some overdose prevention conversations. But I think, things like the planning councils in our cities, with this partnership with community and health departments, can really help, enhance these partnerships by making sure that the programs that truly have the trust of those populations are the ones that are getting funded, and they're truly harm reduction. Because we see programs that are not harm reduction and basically are turning drug users away getting funds. And that's a scandal when drug users are so highly impacted by this endemic of HIV, Hep C, and overdose. So, I think the council and people like UCHAPS can also be very strong advocates for that. That's my 10 cents.
So thank you for that, Paul. Thank you so much. Anyone else have anything to add to that statement? And how can we institutionalize our organizational commitment to improve drug user health? No one? Okay. Well, let's move on. Oh, okay.
Come on, nigga.
So, I guess for me, when I think about the improvement of drug user health for Texas, I won't necessarily speak just about Houston. Our Texas Department of Criminal Justice System, all of those prison units across the state of Texas, there are over 100 of them. That is where most of our drug users are.
Right.
So for us as a state and a city, I think we have to increase options when it comes to treatment facilities. We don't have enough that are available to drug users across the city, across the state, that are free and accessible for people who are low income. So I think that's our biggest area. Obviously, while they're incarcerated, prisoners are getting way better health care in Texas than once they're released and return back to their communities. And it shows in their health outcomes.
Yeah, that's a bad situation. It sounds like that law enforcement assisted diversion is something that, certainly maybe Houston and Austin would be two good places to pilot that.
And it looks like
Houston. Sent you that link. It's
yes.
a really good program. It really helped.
I looked it up, and it looks like Houston is developing the program. Mm-hmm. We have for many years had a drug court here locally in Houston, a local drug court diversion program. There's even, I believe, at least one or two prison facilities that you're not necessarily incarcerated, you're in treatment, but they're only like a couple. And of the over 160,000 people who are incarcerated, very few people actually get the opportunity to do it. And so those are the folks who, they're prisoners. When it comes to Harris County Jail, folks who are just currently detained, so they're waiting for their day in court, they could be in Harris County Jail for a very, very long time, and there are very limited treatment options for them.
Mm-hmm. Yeah, see, the difference with the law enforcement assisted diversion is that it's pre-arrest. Mm-hmm. So, and they don't have to abstain from drugs. So you don't set this impossible bar. It just says you got to go to case management, work with case managers. That could include abstinence, or it might just mean you're not getting in trouble, but you're starting to regulate the way you use drugs in a way that doesn't get you into situations. And that's all you have to do. So, you stay out of prison, you don't get that record. So you don't get that thing where, you get help getting other resources like food stamps, and case managers are helping you, divert your attentions as well towards more healthier ways of engaging. So that's something that would really help, because I have no doubt what you just described is all about racial profiling, totally, capitalizing on crime. Lots of private institutions that are getting boondoggles to run all these people through the courts. It's a fucking sick disgrace.
Mm-hmm. Agreed.
This is David. Can y'all hear me? Yeah.
What's up, David?
Sure.
Hey. I think one of the things that came out of that presentation I think is really key is that this thing has to be led from like the higher up. So really about institutionalizing it, it has to go through like the government first. not first, but it has to include government. I feel that as grassroots and as and as like, as CBOs and whatnot, we're constantly dealing with sort of like crisis mode. We're always dealing with the immediate. And it's really hard to engage current drug users or community members in that process because, it's about that, it's about really having to deal with survival life sort of moments. And it really takes the money and the power behind that the government has to really push this forward into institutionalization. So I feel that, in San Francisco, we've been really lucky with that because we have a lot of folks really pushing for it. New York has demonstrated that. Philadelphia has demonstrated that. Because really, it's going to take funding drug users to be able to push the policy forward. It's not, as much as we want to do the work, we can do all the research behind it, but it's really about putting the money and the overarching sort of like longevity of a project like that within the confines of something that's structured. Because, we come and go as activists and as providers, but really it's going to take that kind of sort of sustainability to push things forward. And it's difficult because, as much as, Sunday, Paul was posting on Facebook, video and images of our new mayor, promising, safe consumption sites here in San Francisco, which is great. But it's one of those things that it takes somebody like the mayor to push this forward, to like, we're ready, we're all ready. There's a few things that are happening legally, which is why we haven't done it yet. But it's something that has to have that kind of visibility for it to move forward. And at the same time, we're sitting in our HIV planning council that includes care and prevention, and a lot of the folks who are on the care side don't get it. I'm like, do you understand? This is the same consumer, whether it's HIV care or prevention, it's the same consumer. And a lot of the folks on our council, like, we don't get it, but we're going to support you guys because you guys say we should get it, so we will. And that's sort of like the divide. It's been so centralized within just specific folks that are really pushing drug user health that it hasn't really gone across a lot of the different sort of like silos that we still see within our own sort of communities of care.
Thank you so much for sharing. Okay. Well, does anyone have anything else they would like to add to the question of how can we institutionalize our organizational commitment to improve drug user health?
I got a quick one, just practical one, that what we did in San Francisco was back in the days of our prevention planning group before we were an integrated community planning council, we had a drug user health work group, and it basically laid out a sort of roadmap for how to help institutionalize drug user health. So it was really about holding the contracts, the DPH, when they give out a contract, to make sure, for instance, that people were trained in overdose prevention. You had to have that in order to receive the funding. You had to have harm reduction. You had to be a real harm reduction. There would be accountability built into these programs to make sure that in order to maintain and retain their funds, that they had to check these boxes, and when they had their evaluations, this would be a hard and fast, you need to have done this or you get the money yanked. So that's the only way, is to write it into the contracts to institutionalize it. And we're still reaping the benefits of that group, which included, this is about 3 or 4 years ago, and it included having SIFs, and institutions move slowly, but now the DPH and the mayor are all on board for having the safe consumption spaces or the safe injection facilities. So I think that, again, this is a good tip for the councils, is we as councils can get this into the actual contracts that the city put out for their RFP, and make sure that, that things like, what is your policy when somebody has used, that you don't just kick a user out of a program for using when you're being funded to work with drug users. That is an absurdity. And it happens a lot of programs where they get a urine tox and they kick them out. It doesn't make any sense. And we need culturally competent programs working with drug users to reduce, their health outcomes and improve their health outcomes, I should say. And it doesn't just mean abstinence. We can't just measure, getting people housed, we know they do much better. People reducing their substance use, they do much better. It can't just be measured by did they give a clean urine, which is what a lot of programming is doing, and it's just disrespectful and it's not evidence-based. So that's my final one on that.
Thank you. All right, so you mentioned a lot about funding a few minutes ago. How can funding decisions, how are other ways funding decisions advance our efforts to improve drug user health? Anyone can jump in. How can funding decisions advance our efforts to improve drug user health?
Well, I think actually David hit on some of that. We need that, like the leadership has to be driving some of this as well. We're going to be bringing it up from, the community, but we need those allies, those strong, like what, the champions of drug user health, like what Magali and Gail and Alex were saying. We have them here in San Francisco. I don't think all health departments do. And, that are really looking out for drug users and trying to ensure that, because these services, so long as you work in partnership with community, people do want good services. It's just they don't want to go to places where they're discriminated against, where they're judged, where they got drug seeker stamped on them, and they just feel like everything they say is seen through the lens of them being, dehumanized as a drug user instead of just being seen as a member of the community that is there for services and deserves the services. So funding has a lot to do with that, and we have to. I feel that we have to defund the non-evidence-based programs and fund the evidence-based programs. And when you think that, what you were talking about, Nike, with programs where people are being mandated to these programs where they have to stop using drugs, and the 97% failure rate in those programs, and yet because law enforcement wants to be seen to be doing something, and there's boondoggles for these programs where they're just getting free money because they don't work, and yet they still get all these people forced through their doors and into these programs that are not evidence-based and that don't work. So that's some reform in our way that we fund that has to be looked at.
Thank you. Everyone here in the room is shaking their head. Yeah, right along. Thank you.
So this is David. So one of the things that was really great about what Paul was mentioning is that we had done several years ago was that we really did push the health department to dedicate a certain amount of resources, really, of like staff time and meeting staff and whatnot, to put together. I think there were like 10 drug user health recommendations, or recommendations we put forward that to move forward to really affect not only HIV and Hep C, we really need to focus on these 10 points. And part of that push was also saying, as you move forward and put out these new contracts, you really need to standardize, harm reduction. What does that look like? You really need to, quote me if I'm wrong, Paul, I think we actually said you really have to put within everything that you do, a component that really addresses drug user health. Didn't we do that?
Yeah.
I remember part of that. The difficulty, though, is that we're actually, and to be really honest right now, is monitoring. Because, the folks that monitor these contracts are business folks. They're not really sort of providers or community members. So we're trying to still put movement into that. But that was part of our deal, saying, if we're going to move forward with providing, these approved funding allocations, A, B, and C have to be integrated within not only your institution and your policies, but as well as in the program development. And that was one of the ways that we were able to leverage some of our community power into the way that we supported drug user health. On the other end of that, through those recommendations, was how we were then able to put together and really work in partnership with our government representatives, was to put together sort of okay, now this is done, how do we now move forward with a task force and really addressing, safe consumption sites? And to be honest, it was really funny because we did this presentation, and the health department was like, okay, so we're not going to touch this with a 10-foot pole, and it was a lot of anxiety around it. And as we kept pushing forward, and really meeting with a lot of the local leaders, it became easier for them to actually be able to talk about it and handle it. But it was because we were able to really leverage not only our power, but leverage actually, our connections through that to local leadership, you know, and having these conversations with folks. And now the conversations with folks, as, you know, I think the past couple of months, I've been going through different, you know, funding request ask meetings with different sort of like government officials here locally. You know, the response is always like, yeah, we know that. Yeah, we know that. And everyone's always like, yeah, although it's not a, you know, it's not a set thing. Well, we do see that we want to put us, you know, because we're really specific. We want, you know, $2 million for 4 specific sites for like this long, you know, demonstration time. And they're all on board with it. So it's really leveraging all those aspects of it and making sure that whatever policy we move forward is actually in partnership with everybody to make sure that, you know, we're all in it together. Because when I go to those meetings, it's not just HIV. It's actually like housing. It's this, it's that, you know, it's all these different folks that this is what we really want to really affect the folks that we're addressing.
Awesome. Thank you. Sorry, I had to mute it. Thank you so much. So moving on to the next question, how can our partnerships and community outreach efforts how can our partnerships and community outreach efforts help to advance, what?
Yeah, something's missing.
How can our partnerships and community outreach efforts help advance drug user health? I'm going to make that question. I'm going to pull two of them together. How can our partnerships and community outreach efforts help to advance drug user health?
Well, I mean, in San Francisco, that's definitely happened, because what we saw here is from our syringe programs, we had you know, HIV and Hep C testing added to those programs. We obviously already had the overdose prevention thing, and then now we've got things like lockers for people to keep their Hep C meds. We've got nurses and doctors coming to the syringe programs and treating people for Hep C without them ever having to go to a clinic. We've also got people getting on PrEP through syringe programs. So getting outside the 4 walls of the clinic is one of the latest initiatives that San Francisco is starting to do. And it's already proven productive, you know, and we have like STI testing happening at syringe sites, so people don't have to go to a clinic and wait in line and feel all that. You know, it's like when you have a syringe site that's a really loving space for drug users, then you should just have every other service there too, because people want to get them from people who they already know were all in for them from the get-go. And that's something that, you know, our city's been good at utilising the partnerships, and I don't think it's true for all cities. And so to keep these silos, and STI testing only happens in this one place for free, and there's like a gigantic wait, and then maybe there's a $10 co-payment, and you know, and we know that the STIs drive HIV. You know, it's like we need to do a better job of getting these barriers out of the way, particularly for drug users, that there's spaces that they already go, bring the services to those spaces. That would be the easiest way to capitalize on that cultural relationship that these agencies have. And we've seen that to play out in San Francisco, and we have the least overdoses. And you know, we test a lot of people at our syringe programs that probably never go to other services, and get them through treatment too. Like, we've treated over 100 active drug users at my program, and like, you know, a bunch of them came through the syringe program.
That's awesome.
Mm-hmm.
Awesome. Thank you. Anyone else have anything that you'd like to contribute to the conversation of how our partnerships and community outreach efforts can help to advance drug user health?
There's one thing I forgot to mention, folks, was that health departments are never really going to hire active drug users, not knowingly. CBOs can have ways of integrating those folks, whether like we do a lot of peers and we give them gift cards, because even our agency is so huge now that our HR, that's a challenge. But as we move drug users into the mix, at least stipends, at least empowering them, giving them opportunities for trainings, et cetera, you know, that's something that we can do that absolutely dramatically. People like to see people who look like them on the other side of that desk handing them services, you know. So that's another, you know, big way of increasing the uptake in services by drug user involvement at the service end.
Yeah. See some folks nodding as well. All right.
I guess I can just say that, since there aren't actually a lot of jurisdictions from the South on this call, that we have a lot more work to do around stigma and the discrimination here before we can even get to a place where we're holistically addressing drug user health. Texas got really, really close last year in ending the syringe exchange ban. That did not happen. It was not successful. So for those community members who I know help do clean syringe exchange programs, they're underground and technically illegal. So you can already imagine, who's actually getting access to these and who isn't, and how limited it is. So I think for us, we would probably actually benefit more from getting some more policy and advocacy in this area so that we can have comprehensive programs to address both. I also mentioned the fact that we don't have a whole lot of drug treatment programs. Our state under Governor Ann Richards had treatment programs all across the state. You didn't have to have a lot of money to get access to treatment programs that were harm reduction based, but now they are few and far between. So for Texas, we need to push a lot more on the side of policy and advocacy change just for basic funding to start programs. And I can imagine that in some of the other states and jurisdictions, they are struggling with the same things in the South.
So is there a way that people like maybe San Fran or New York or Philly could help do some TA around that for you folks?
I think that would probably be super helpful. So before Texas's next, HIV Advocacy Day with the legislature or something like that, because it's great hearing y'all's stories about positive outcomes. Here are the interventions that work. Here are the interventions that don't work. If we had some, fact sheets that said this and this and this, if you do these things, this will work, and this is how it, helps. When it comes to the tax dollars, and then also the individual and community's health. So yeah, I think that would actually be very beneficial to us, with the caveat of our lovely legislatures down south. They don't always take well to hearing you should do this from the West Coast and the East Coast. So we would just have to, we can play with that, how we put it.
Yeah, I think we could just support you by showing you a lot of the data that proves that these are evidence-based. They work, and they all save funds because you're getting people upstream. You're getting people with Hep C who would have spread it, but you got them in and you got them treated, so now they're Hep C negative, and they're not spreading it, and they don't get liver cancer, and they don't cost all this extra money down the line. So we have good data that we can show what the sort of sensibleness of this approach, and just present the facts and no judgment to your legislators.
That'll be helpful.
Sure.
Nikkei, when is your next advocacy day that you're talking about?
It should be February or March 2019. We're actually having a little, it's interesting who usually does the main coordination of Texas's Advocacy Day. Is Legacy Community Health Services, and last year they were having some challenges with it, so I'm hoping that it's going to happen next year, February, March, but we may actually need support just coordinating it to get it done.
Okay. Well, just let me know. However, we over here at UCHAPS can help. Okay, so for the next question, how can we engage and balance both community and technical expertise in our efforts?
Hey, this is David. This is actually in response to this question, but really, Nikkei, I know how challenging it can be, and I totally understand that with the South. My first experience really doing a lot of advocacy work around this was in rural areas here in California. I know Paul worked in South Florida also. And one of the things that really helped us out specifically with this question was going to that same route of really, when we're talking to like a bunch of like religious leaders, stuff like that, we put together like an ask. I started talking to the police captains, and so I'm being like, hey, you know what, this is what we're trying to do, stuff like that. And a lot of folks, you believe it or not, there's a lot of folks that actually do ally and, understand it. And they're just like, well, because of the bureaucratic system, I can't really be out about it at the job, but I would sign on to something like that if it was a bunch of different folks. And that's what really started us getting a lot of pressure off of some of the needle exchange stuff that was happening on the streets. We still got some harassment from folks, but it was like small little movements like that where it was really, putting like, community health and community sort of like advancement forward and really getting really small amounts of folks that are supporting us, but it was across the board, and it wasn't just specifically just folks that are like dealing with one specific issue. So like I remember I had partnered with a bunch of parents also whose kids had gone through overdoses, and they were like, oh yeah, no, we'll sign up on that. And it was one of the ways that we were able to get a lot of pressure off of the needle exchanges, because in this one county in Santa Cruz, the needle exchange was specifically in downtown, and it was very sort of like supported area, very affluent. And I was trying to get something started in like, Latino neighborhoods that were like agrarian, farm workers. And it was getting so much pushback, but really it was me going to a bunch of churches and being like, this is what we're trying to do. And they were like, oh yeah, no worries, we'll support that. And we still got, pressure, but it was not as stigmatized as I thought it was going to be. And it was that old school, really working with folks like that to get that started and putting together like a mission statement that was being pushed through, and something that was able to refer back to as we moved on, try to expand services. But yeah, that's one of the ways. And I think it's old school sort of like grassroots organizing. I just cannot fathom how difficult it is for you guys in the South, specifically in Texas, because I keep having conversations with folks about Texas all the time. And I do not envy the work you have ahead of you.
Awesome. All right. So before we move back into the room, if we could just take 1 minute just to give what would be some next steps. What are our next steps in addressing drug user health?
I think one of the next steps is what David mentioned as well, is like, coming up to what are sort of some standard definitions of what we mean when we say drug user health. So it means equitable access to services. It means that your drug use should not impede your ability to access any particular service, things like that, helping people flesh that out, and so that they can demand that of programs that maybe aren't being drug user. It's like trauma-informed care. People just say, we're a trauma-informed care program. Then when you try and do an intake, the very intake form they use is fucking re-traumatizing people. So, you can't just put a little label on something. So we want to kind of truly have drug user health initiatives as part of these programs. So I think that we could help defining that, extrapolate on what that language is, how that looks, how that looks for a HIV test, how that looks for a Hep C test, there's programs where if someone's high, they won't test them, but they can totally consent to a test. They're just high, but they're completely, they can consent to a test. So, there's a myriad of ways that drug users are either denied services, or they're required to go through some more hurdles to get services, or it's just made so uncomfortable that they choose not to participate. So I think that this is about welcoming drug users, creating an environment, and the next steps could be, maybe a sort of, whether it's a white paper or just, a guide to improving your drug user health, aspects of your programming. Because I don't think everybody gets it,
Mm-hmm. Agreed. Anyone else have anything for next steps? No, that was it. All right. Well, I'm going to bring everyone back to the main group. And when we get back to the main group, our program coordinator, Martinez, is copying down notes feverishly as you guys are talking. He's saying hi to everyone. So he'll be able to report back on all the great things that we talked about today. Thank you all.
Hello, Jeffrey.
Hello.
Miss you guys.
Hi. Are we being put back in the same room now?
Yes,
Yeah.
we're all in the same room now.
Okay, great, great. Can you see if Ivan made it back into this room? Adrian had to jump off and go to another call.
Yes, Ivan's here.
Okay, great. So we are all back in the main room. Let's see, let's have some discussion around what happened in the breakout sessions. One of the things we want to make sure that we're doing is if you're not speaking, please make sure that your phone is on mute. And then in order to speak, you can unmute your line. So let's take a moment. I'm looking at folks' pictures, some of which are flashing, and it seems like everybody is muted except for me. So thanks again to our presenters for taking the time to share your work with us. Oh, I'm sorry, I jumped too far. I'm obviously reading the script. So let's have some conversation now around what happened in our breakout rooms. And since there were only 2 of us who were able to actively speak in my breakout room, I'm going to pitch it to community, that very valuable part of the work that we do, to talk to us a bit about your conversation.
Awesome, thank you. So I facilitated the community group, and I'm going to ask one of our newest staff members, Martinez Brown, our program coordinator, to just talk about some of the notes that he copied out from the community session.
Thank you, Kenya. Hello, everyone. For the first question, how can we institutionalize organizational commitment to improve drug user health? I got a few comments from our group, and one of the comments was health departments have to partner with community-based organizations. Syringe, overdose, Hep C, HIV programs are more likely to engage and link people. Better funding is required for community-based organizations and health departments to partner with community-based organizations. HIV planning councils can help enhance partnerships, and also UCHAPS can also be strong advocates for that as well. I had another comment from that same question. Texas Department of Criminal Justice System is where most of the drug users are. Increased treatment facility options, especially for free and low income persons, and also those drug users are receive much better health care in prison, which is something of concern. Also wrote down that Houston and Austin are great places to pilot such programs as well. And I wrote that it is hard to engage drug users because of life and survival issues. This will also take funding and a lot of drug users to push initiatives forward, and will also require more visibility from leadership in certain areas, such as mayors, politicians. I had a question, a response from Paul as well, that drug user health groups will also help contribute to more success and require DPHs to be trained in harm reduction, and also to write it in contracts to have more accountability. The second question was, how can funding decisions advance our efforts to improve drug user health? Leadership must drive this, encourage champions to step up. People such as Magali, including health departments, defund non-evidence-based programs. And then some more contributions from the group. There's 10 drug user health recommendations. Some of them include standardizing harm reduction, components that address drug user health, leverage community power into the contracts, keep pushing this, and also include local leadership in the conversation. The third question how can our partnerships and community outreach efforts help to advance drug user health? Some of the responses were HIV, Hep C, add HIV and Hep C to programs, have nurse and doctors treat individuals before going to the clinic. Having STI testing at syringe sites is very helpful. Syringe sites are typically friendly to drug users, so keep the services there. Also, the comment that health departments won't knowingly hire drug users, so get drug users into the mix and at the table, because they like to see people like to see people like themselves. So let's go to the other group, to the health department group, and then we can see some of their outputs and their responses to some of these questions as well, and we'll come back to this group afterwards.
Okay, so a couple of the major themes that we covered in the health department group in terms of institutionalizing our organizational commitment. A really big theme that came out was funding, so figuring out how to create funding opportunities that explicitly address drug user health and are what the community needs. So, for example, speaking with our community organizations about areas where we can offer support, offer data, so that they can better advocate for themselves and for some of the needs that they recognize in the community, that in places that health departments may not be able to go themselves. In addition to those funding opportunities, it's important for health departments to do internal evaluations, figure out spaces where opportunities may exist already but aren't being adequately utilized, where drug user health can be emphasized and more explicitly addressed. In terms of how funding decisions advance our efforts to improve drug user health, one suggestion we had was adding weighted questions around drug user health to grant applications that health departments might have or might offer to the community. Emphasizing the importance of hiring people who may use drugs or have used drugs in the past. And in terms of how our partnerships and community outreach efforts can help to advance drug user health, we discussed ways that health departments can partner with some of the organizations within the community to discuss drug user health issues, or to act as a liaison between maybe law enforcement and community partners to work on drug user health issues and topics. I think that covers the bigger ones that we discussed in the health department group.
Okay, so some more questions from the community group, or answers, I should say, to the question, how can we engage and balance both community and technical expertise in our efforts? The response was, put together an ask with influential community entities such as churches, police, and parents of kids who have OD'd to get more buy-in, was one response. And that was the only response for that question. And the next question, what are our next steps? And the response was standardized definitions of drug user health. Make this more clear. Create a welcoming environment for drug users.
On the government side, our response to the question of engaging and balancing both community and technical expertise in our efforts was looking at who the experts are within our communities and highlighting best practices being used by these experts. And as for our next steps, we have a couple of different responses to that one. One was tracking spikes in overdose and what potential causes of those spikes are. We had additionally had a discussion about social determinants of health and how health departments can better implement that knowledge in undertaking drug user health topics.
All right, back to you, Jeffrey.
Okay, good. So thank you all for your input. I wanted to add one thing that I think is very important, and that is when we talk about advancing the efforts to improve drug user health around funding decisions, is that there are times when our jurisdictions, particularly, well, I've seen it happen on the community side and on the government side, where funds get in the house, let's say, but sometimes the bureaucracy of the house makes it a challenge to get the funds where they need to be as soon as they need to be. Doesn't mean the funds don't make it there, or that something, off is happening with the funds. It is just the process in some of our organizations, whether they be government or community. So I do think that that is important for us as an organization to continue to consider, and how do we help each other out in those efforts. So I want to add that, because I do think that that has been a challenge for many of us on community and on government levels. So I want to thank you again to our presenters for taking the time to share your work with us. Before you log out, we do have it's about a 10-second survey, or it'll take you about 10 seconds to complete the survey. You'll find the link to the survey in the chat box. So once you've found that link, please go ahead and complete that. And then we will be back here tomorrow at, let's see, 1 p.m. Eastern time for the second part of our drug user health roundtable, our conversation. So it's been great talking with you all today. Please make sure that you complete your survey, and we'll be back here tomorrow, same bat time, same bat station.